5,
Ayush, I will
4,
introduce you and then you can start.
3,
Sure.
2, 1. We are live now, sir.
Okay. Good afternoon, all. We are bang on afternoon time, 12 o'clock. And this is a new initiative from MISSAB, myself, Dr. Gururaj Sangwandimat, education in charge, MISSAB. We are starting this webinar series, and this is the first of its kind. And today, the webinar is along with SMISS-AP, and we have a stalwarts from SMISS, and Dr. Ayush Sharma and Dr. Arvind Kulkarni kindly agreed to convene this webinar and host it. And I welcome Dr. Ayush Sharma. You all know him. He doesn't require any introduction. He is one of the well-known MIS surgeons of India. Over to you, Ayush. Let's start the proceedings.
Okay. Thank you, Gururaj. It's an honor and pleasure. I belong to both the societies, to MISSAB and SMISS-AP, and it's always an honor to conduct something. So, we have the best and the best of the faculty here. We have Dr. Jacob from Singapore, Dr. Park, and Dr. John Choi, who will join us soon. These are the best known names in the field of MIS surgery. Of course, Dr. Arvind Kulkarni is just joining us. The idea of this webinar, the flow is to first tell you the basic of the surgical techniques of the MIS procedures, like the MIS-TLIF, the OLIF, the TLIF using the UBE technology, and ALIF, which Dr. Choi will cover. Once we have gone into the techniques, we have case presentations from Dr. Gururaj, who will a single level fusion where we will discuss how each and every option which we talked about can work and what is the pros and cons. And then we have a stalwart like Jacob, who does a multiple level MIS fusion. And then again we'll go how the same principles and techniques vary or differ, and how you can apply in your day-to-day practice to choose one technique over other. So by the end of the webinar, we expect you to understand how MIS techniques when it comes to fusion surgery, how they differ, what are the indication, when you should choose it, and hopefully the panel here will do justice to the time you are giving us. Dr. Arvind, are you ready, or should I go with the first? You are muted, please.
I think
I can start.
Okay. So I think MIS-TLIF, is the bread and butter of any MIS surgeon. And to start with is Dr. Arvind Kulkarni, who is, one of the biggest name when it comes to minimally invasive spine surgery and MIS-TLIF. So over to you, Dr. Kulkarni.
Yeah. Can you see my slides?
Yeah, we can see your slides. No problem.
So are they in the slide sharing mode?
Yeah, now they are in the slides.
Yeah. So thank you so much, Ayush. Thanks, Guru, for this initiative. It's an honor and pleasure to be the opening batsman of this educational webinar series. I'll not waste much time. I'll go through a few slides just to show the indications of MIS-TLIF, then show my video. So MIS-TLIF has been my friend for last 15, 20 odd years. I've been doing it day in and day out. It is basically an elegant, minimally invasive version of its older self, that is TLIF. TLIF itself, the open TLIF came as a sunshine when PLIF was the gold standard. PLIF was, of course, a great technique, but there was a lot of adversities associated with PLIF in terms of neurological complications, dural tears, etc. The option of excising the entire facet joint and using your lateral approach to decompress and achieve interbody fusion was a revolution. So basically, MIS-TLIF built on the steps of the open TLIF. So basically, it consists of two main steps. So one is decompression and fusion. This is achieved usually using a tubular retractor, and this is for long term. So the fusion has to happen over a period of time. And the second step is basically establishing this pedicle screw rod assembly. So this provides immediate stability, and it also helps in getting your alignment right. So I'll start with this example. So this is a patient, this is a patient where open TLIF would be a danger to do. This patient had a laminectomy done quite some time back, and following laminectomy, she never got back out of her bed. She had all comorbidities in the world: renal failure, diabetes, hypertension. She was obese, low protein levels, and she had this midline incision which healed with secondary intention after a plastic intervention. So it almost took 4 months for her to for the wound to heal, and she never got out of the bed after surgery. You can see this degree of facet effusion, the absence of inferior facet here, and the instability. You can imagine how bad she is in terms of back pain and leg pain. Again, going through the same incision and achieving a TLIF in this particular patient would be a disaster. So in such a case, MIS-TLIF comes as a blessing. So you don't have to go in the midline. The approach is lateral. There's less stress on the midline structures to heal, and you achieve your immediate stability with pedicle screws and rod through percutaneous pedicle screws, and interbody fusion through this tubular retractor. Patient is up the very next day and extremely happy. So, this is one step, as I said, above TLIF. So this is something which we published. This is just one of the indications. There's no indication under the sun which cannot be managed with minimally invasive TLIF. It's degenerative listhesis, which is one of the commonest indication for why we operate. Then is lytic listhesis. Then a whole gamut of indications. I'll go through each of them quickly. So this is a case of degenerative listhesis. You can see the lytic listhesis. You can see the degree of the kind of lordosis one can achieve with this particular technique. Again, another case of degenerative listhesis with stenosis done with minimal access. So you can again appreciate the degree of lordosis, height achieved at the L4, L5 level, all done through the tube. Another patient with a collapsed disc. You can see there is hardly any movement at the disc level. Again, you can achieve an excellent correction of listhesis as well as achieve very good height through this tubular retractor using minimal access. Another few indications. This is a case of spondyloptosis, which was done using minimal access. One of the world's first reported case of spondyloptosis done using minimal access. Another few cases we published a series of high grade listhesis, all done through the tubular retractor. Another good indication is a large central disc herniation, wherein because of access you can go, posterior lumbar interbody fusion becomes difficult. So exercise the entire facet, go from one side, exercise the entire disc, and achieve your interbody fusion. Again, a similar case. Selective fusion in patients with degenerative scoliosis, where only one particular level needs to be decompressed, then fused. Spondylodiscitis, where you achieve interbody fusion and give pain relief. Again, multi-level TLIFs can be done using these tubes and this percutaneous pedicle screw rod assembly. This was done in a patient with post-laminectomy instability. So one of the arguments against TLIF in comparison with other options, that is ALIF, OLIF, is the difficulty in achieving good amount of lordosis. So of course it can't beat the other two surgeries, but with newer expandable cages, and if manipulation of facet joints on both sides, basically excising the facet joint on one side and internally destabilizing it from when you do a contralateral decompression. By doing that and by using an expandable cage, one can try to reach the same degree of lordosis that is possible with ALIF and OLIF. We have our own technique which is published, so wherein we actually insert the cage, the flat portion of the cage, and turn it around to get the lordotic part inside. So with this, the disc elevates and lordosis, the disc, that particular segment lordosis, we achieve a fair degree of lordosis with this particular technique. About 10 degrees of lordosis one can achieve by this insert and flip technique. Now I'll jump to the video. I have to just stop this and yeah, so this is the video. So I'll brief you. This patient is a case of spondylolytic listhesis about grade 2. So the technique which we use here is basically using a 3D C-arm to navigate our pedicle screw entry and navigate major steps of the surgeries. Of course, the most common way of doing this particular surgery is using a C-arm. So one can use a C-arm, one can use a 2D C-arm, wherein you get only two-dimensional, that is, barring the axial images, one can get sagittal and AP imaging. This is something wherein you get, the one which I'm showing is somewhere is a possibility wherein you can get imaging in all three axes, that is sagittal, coronal, and axial. So it's a 6-minute video. So this is a lytic listhesis. Patient is positioned prone. This is an isocentric C-arm which captures these images and they are converted into CT images which are integrated with the navigation. So we are inserting this Jamshedi in the 4 holes, that is L5 and S1 pedicles, through which the guide wires are passed. So this gives you an opportunity to aim your pedicle screw in the right direction so as to get the maximum length and maximum diameter of the screw in. So we instrument the opposite side and insert a rod there. So these screws are navigation guided. We insert a rod on that side to get correction. This is after doing the interbody fusion on this side. So I pass screws on the opposite side. Now I am dilating the opposite side, that is my side, the symptomatic side. So the tubular retractor is in. So it lands on the facet joint lamina complex. So you get less bone in lytic listhesis compared to degenerative listhesis. So you usually avoid using a burr. So get as much bone as possible from the pars, the part of the lamina beneath the pars, the facet, that is the inferior facet, and the overhang of the superior facet on the disc. So once you do that, the flavum gets exposed. The flavum beneath the ipsilateral lamina and the flavum that is covering the disc space. So laterally it is the capsule of the facet joint plus the flavum. That is what you excise. And using navigation, you know the direction of the disc space. Sometimes it can become a bit difficult at L5S1 if you're not in the right direction. You hit the end plates and damage the end plates. So it's very important that the tube as well as the tube basically navigates the direction of the disc. So they both should be in the same plane. And of course, navigation helps you so this is what you do when this is what you do when you have a case with the degenerative listhesis. So I'll pause here for a while. So when it is a case of degenerative listhesis with stenosis, the steps increase a bit. You have to do a contralateral decompression. That is by tilting the tube on the opposite side and doing an over the top decompression. So you tilt the tube to the opposite side, drill the base of the spinous process, drill the inner cortex of the opposite lamina. When you do that, you'll see a complete sheet of ligament flavum from one end to the other, and you excise it, and you basically see the root on the opposite side. So that is how you confirm IPSI and contralateral decompression as shown here. So this is the flavum, this is the contralateral side, and this is ipsilateral side. So then your tube comes back to your original position, and then you start your disc work. So this is the amount of graft that is harvested from the excised structures. So you insert cutters, shavers to elevate the disc height, and then you put the rod on the opposite side. There are various ways of inserting this rod. This is called the sextant technique. So you see how the rod is going in, and this is when you will need a C-arm again. And by tightening the reduction screw mechanism, you can pull the L5 back on S1. At the same time, you're manipulating the disc height with the shavers on the ipsilateral side. If you look at the C-arm image, you can see a sudden correction in the degree of listhesis. So once that is done, then you check the size of the cage that you're inserting, and you pack the anterior part of the disc space with bone graft, and then put your cage in, and these are screws on the ipsilateral side that you're inserting right now. So once that is done, you insert your rod on the ipsilateral side. So this is the size of the scar. So, basically this 3D navigation helps in reducing radiation. It increases the accuracy of surgery. It minimizes contamination. Since you are right, most of the times, the incidence of or the risk of going in again to correct your pedicle screw direction, etc., is minimized. Basically, it helps in optimizing precision and reducing your operative time. Thank you very much.
Thank you, Dr. Arvind. So I think we can discuss the technique detail and indication when we discuss the case. So that will be more, fruitful. But now you have been doing for many, many years, and the implants and everything now has changed quite a bit. But what about multi-level? Do you still feel it's a challenge in spite of the, uh, development in implant? If you have to prefer 3 level, do you have any, or 4 level of MIS-TLIF? Do you have any hesitation, or it's fine with you?
No, I usually stop at 2 levels. Beyond 2 levels, gets a bit taxing and boring. I've done 3 levels, but I wouldn't encourage this. Maybe a a surgery like OLIF is much more handy in doing a multi-level surgery because I think it is quicker. Two-level is something which I do very easily. I mean, I will never hesitate or shudder to do a two-level MIS-TLIF. In fact, using the same hole by changing the direction of the tube, you can achieve two-level TLIF quite easily.
Yeah, I agree. I agree. So let's see how that is the beauty of this webinar is you for everyone to understand how different techniques have their own indication, even in the best of the hands, how they work and how you can customize this to work for you. So maybe we can discuss more when we go to case discussion. So I will start with my presentation here, which is on the OLIF, which is the next technique. So, like Dr. Arvind was telling, these are OLIF is another beautiful MIS technique, and it has its own, own indications. You can do it for one level, multi-level, and maybe Jacobs will come in and show multi-level how he tackles it. That will clarify a bit of things for us. So if you look at it, we have many ways to do fusion. We are just Dr. Arvind Kulkarni just spoke about the MIS-TLIF. I am talking about OLIF. Dr. Park will talk about UB fusion, and ALIF will be covered by Dr. Choi. So if you look at the technique, it is nothing new. The lateral approach or the retroperitoneal approach to spine is something which started way back in 1944. But the problem is, this is where the major change came when they started doing a minimally invasive lateral approach in 2004. So this is where the technique changed. Instead of doing a big razor sharp incision, a minimally invasive technique was developed. But the problem with direct lateral approach is that you need to go through psoas, and psoas is not just a muscle. You have many, many important nerves. Just to enumerate some, you have genital, femoral, inguinal, and femoral. So these are your, some of the natural structure which is there, and you're going through them. You need to be aware of them. You can use neuromonitoring, but still there is a risk you might damage them. And that is where the whole idea came, where instead of going through the psoas, OLIF was developed, where instead of going through the psoas, you go anterior to the psoas. And this is the technique I will talk about. So this diagram, if you look at this, shows the footprint of a direct lateral or the XLIF or DLIF over OLIF. Even if you look at the trajectory and the footprint of the cage, it shows that while if you're doing the OLIF, your chances of you hitting some of the nerves of the lumbar plexus are less likely. So this is, I think, is the most important slide. Whenever I talk about OLIF, I always talk about the trajectory of attack. So this is your trajectory of attack in OLIF. And if you understand this, half of your problems are gone. The trajectory of attack is a natural corridor between psoas and the aorta. And if your patient has a good trajectory of attack, OLIF should not be a problem, or you have to be as competent as Jacob, who doesn't care about the trajectory of attack. He can do OLIF in each and every case. So these are the way you can do OLIF. So, but as a beginner or someone who wants to do these cases, please understand what we are doing here is exploiting a natural corridor which is there in most of the patients. And this is very important for you to understand if you want to become a OLIF surgeon. And this is the video which will show how a OLIF done. The most ideal level to start a OLIF is L34. This is a 65-year male. You can see the L34 is tilted. He has back pain and neurological claudication for almost 10 years. If you look at it, there's significant collapse of L34, and it is shown in the X-ray and the CT scan as well. And if you look at it, it is like sort of a mild tilt as well. So this is the position of the patient. Normally, the left side is up. Most of us, we prefer to go from the left side, so we keep the left side up. You need to confirm your imaging before you start. You need to have a true AP and true lateral before you start. And normally, this is the incision how we take. It's slightly anterior, 3-finger width for 4-5, and 2-finger width normally for me if I'm doing 2-3 or 3-4. Once you have, this is how I do it. I mark the levels, the anterior and the posterior border. I mark my incision. And the beauty of this approach for me, Dr. Arvind showed all fascectomy and everything. Here, if you see, I will only cut the skin and the disc, and rest everything. You're using a natural corridor to approach the spine. So all you are doing is you will be retracting things. So once you have, normally the incision is 2 to 3 centimeter, depending on how thick or thin the patient is. Once you have taken out the skin, you get a thick fascia, and which is normally there, and you remove the fascia. Once you have dissected the fascia, there will be layers of abdominal muscle, which are very, very easy to identify with, because as you go in, the layers and the direction of the muscle will change. So even if you don't remember exactly where you are, just remember there will be a change in direction as you go from external oblique. So what you see here is the external oblique, and we have gone through the external oblique, and then you will have the internal oblique. And all you can see is, as I go in, there is a change in direction, which tells me that I have gone through one muscle to the other muscle and the next muscle. And once you have gone through the internal oblique, there is transversus abdominis, which you can see, which is the next muscle which comes in. Again, you can see this is the internal oblique. Sorry, so we have just gone to the internal oblique, and from there you again see how the muscles are arranged, and hopefully you will be able to appreciate it. So this is all you need to do, and every time what I'm doing is dissecting it and using my finger to swipe it and to go to the next layer. After internal oblique, we will have the transversus abdominis, and then the fascia transversalis. Sometimes, remember, the muscles could be, slightly very thin or might be absent. So you need to be careful when you're going, especially to the inner layer, especially the fascia transversalis, which I will dissect now. I normally use a finger to dissect it, and you go as posterior as possible to release it, and then so this is what I'm doing here. So I can just pause it a bit. So this is what you can see here is basically, you use a finger to retract all the muscles anterior, so that all the retropedient fell anterior, so you can reach the spine. So I think something went wrong. 1 second. I think the video, stopped. So I'll just go so I was here, I guess. Yeah. So this is where we were. So, so basically, sorry. Yeah, so this is where we were. So after this, once you are inside, I will use the C-arm to confirm the location. So because you can easily be above and below. I always do it under vision. I use some specialized customized tools, to ensure that whatever is there, wherever I am here, I see a 360-degree to do my surgery. So, everyone, as they do more cases, they develop some techniques. So this is how we use this long retractor blades, and the part in the depth is always under vision. So you can see I can see the psoas, and you sort of try to retract the psoas to look at the disc space, and you will be surprised sometimes. So, and I'll show you a few of the images we have captured. The anatomy can have some variation, even if you looked at the C-arm or on the MRI images. So you need to be very careful what you're looking at, and be sure what you're. So you can see we are using this. You can use a Kittner. You can use some Bovies to retract the psoas. And now, once we have retracted the psoas, you can see 360-degree. I have a clear-cut vision, and the disc is exposed, and that is the time we'll start the discectomy. So the dissection down deep is completely under vision, and those retractors, those long retractors, really helps to see everything and do everything. I believe you can see something, the chances of you making mistakes or something going wrong becomes very, very less. So even the discectomy, as you see, is completely under vision. So you start with a complete you start with the surgery under vision, so that you don't make any mistakes, and so that the huge chances of having something or damaging something becomes significantly less. So this is the discectomy. Once we have done the discectomy, after just a small removal of disc, so that I know I am in the right place and I'm in the right trajectory, that is the time I'll start docking my tubes. So we'll just start docking in a short time. So tubular docking is also under. So this wire I don't use now. This earlier we used to use wires, but they are flimsy and then can go anywhere. So I start with the first dilator itself. So you'll see even when you are docking the tube, you have a 360 vision of where the tube is going. You have retracted the psoas. All your anterior structures are also retracted with the long blades which are already there. And once you have docked the tube, the rest of the part is very easy. Of course, you confirm that your docking is good. It should be ideally in anterior 1/3 to middle of the space. And then, you do what you do with any typical surgery. You remove the disc, okay? You prepare your end plates. But understand, in this case, you are in an oblique trajectory. So you need to do an orthogonal maneuver. So this is what is orthogonal maneuver. You come oblique, but you go perpendicular to the disc space. So all your instrumentation, like the shavers, the blades, they're all done in orthogonal maneuver, so that by the time you place your cage, you are exactly perpendicular to disc space. This is a very specific thing which comes for OLIF, because the way you approach the disc space, because of the way the technique is designed. And then you use your trials. Again, look at my hands. So as how it will drop in as I go in. So that is what the orthogonal maneuver is. So this video is slow video at 2x. So look at the hand. It will just move anterior, and it will go out of the small space we have for in the tubes. So I can place the trials perpendicular to the disc space of the body. And and if you are not able to do that, your cage won't be in proper place. So this is important. This is very specific technique when it comes to OLIF. Of course, when you are doing this, you need to check and counter check every time, especially if you are starting. Be sure that you're in the right place, you are in the right position, both in terms of AP and lateral image. So this is where we'll check. And ideally, the cage should be good enough to cover the entire end plate, because that is the beauty of OLIF surgery. You can really put a very, very wide cage. So you can see this looks pretty good in terms of the position of the trial. Once the trial is good, you can place the cage, and the cage can be from depending on the different companies. They can also have some amount of better lordosis. They can come from 6 degree to 12 degree lordosis. And that is where the advantage of the OLIF is. So this is the position of the cage. You can see that it looks pretty decent in terms of its positioning. And then, then you make sure that still there's nothing coming in the way, there's no bleeding, anything. And this is the lateral view. Again, you can see that the whole disc space is really jacked up. And that is, again, what happens when you do a good release and put a decent size case. And this is the beauty of OLIF, whereas you remove your retractor system, because you have not dissected anything. All the muscle, the peritoneal structure, everything simply falls back. And normally the patients are pretty happy in terms of pain and everything, because your dissection and fascectomy is not there. And this is the final image after fixation from the posterior, which is standard MIS fixation, which was done. And this is a 1-year follow-up MRI. And look at the beauty of decompression that has been achieved, not only because you put a cage, but because you restored the alignment. So this was how the surgery was done. But understand, be careful if you see something like this. Sometimes, you can have a lot of abnormal structure. So in this case, although we thought we can mobilize the window, but see, the left lumbar vein was simply sitting at my disc level. So it's a very, very anatomical driven surgery. You need to understand your anatomical structure, and sometimes be ready to convert it to a different technique if it needs to. In this case, in spite of, we trying all our experience, the left lumbar vein was completely stuck. We tried everything, we could not move, and you can see, and we're just where I wanted to do my disc work. So we opted for MIS-TLIF. Now, these are another structure. You can see what you can see is the sympathetic chain. Again, these can be mobilized. I think I use a microscope once I go in, because it allows me to see these small structures. So all you need to do is to push them away from your disc space. And if you can do that, you can easily mobilize them normally, if you do it under vision and you do it carefully, they don't get damaged, and normally you should be fine, even if you have a sympathetic chain coming in your way. Now, this is something which is a sort of a nightmare for any OLIF surgeon. It's a iliolumbar vein. It is a part of the L4-5. It goes from L5 body and goes up. So this is an anatomical dissection in a cadaver. You can see this, the tendon of the psoas, and just below you can see that blue vein which is going up, and it's a iliolumbar vein. Very, very difficult to pick it up on a. And this is the cage. You can see it's a cadaveric workshop, and you can see how close the iliolumbar vein is. But so if you see these veins, better to catch hold of them before they start bleeding, because they are valveless vein and they can lead to a very, very torrential bleeding if by chance you damage them or something like that. So be aware of this iliolumbar vein. And this is one case intraoperative where we had a iliolumbar vein, and you can see we had to put some staplers to coagulate those veins, because I saw some amount of using in this specific case. So we had to, this was a 3-level OLIF, and L4-5, we had the iliolumbar vein, and this is a intraoperative image. You can see how the staplers had been done to take care of the iliolumbar vein. So OLIF is not only about putting a big cage. I think it is more than that. More than the height of the cage, I believe it is the width of the cage and the way it sits on the end plate. That gives it the biggest advantage. You don't have to really worry about the decompression, because the indirect decompression, as you can see here, it really, really works, and it is based on what we have seen over years. You can do it in one single position if you want to. Like you can see, these are navigated screws, Viper Prime from Depu, where a single level surgery can also be done. And you can modify, even if you have a disc space, you can put some endoscope, get out of disc even if you need to. And normally the results are pretty gratifying. But any technique has its complication. And if you look at it, some of the OLIF also has its share of its own complication, but normally they are pretty beyond the permittable limit of complication as compared to any other surgical technique. So you'll have some complication if you look at the literature. So, but this is what I believe. If you can do ACDF, which is anterior approach in a cervical spine, OLIF is nothing but a anterior approach in lumbar spine. The technique, the corridor is there. All you need to learn and do the surgery. And just remember, these are great surgeries, but they come with great responsibility. So learn the technique, learn the anatomy. If you can learn the anatomy, OLIF is not a very difficult technique to execute. And all the great surgeons who do this will vouch by it, that it gives excellent result. And I hope Jacob will have something to show later. So thank you so much. I think I covered as much as I could. And for the sake of time, we should move ahead. I don't know if Choi is there. Choi, are you ready for your next talk, or should we?
Sure, I'm here.
Oh, great, great. So you are right on time. So over to the great John Choi, who will cover another technique, and which is the ALIF, and it is the king of all fusion techniques. Over to you, Choi.
Thank you so much for including me in this webinar. My talk is going to be on lateral ALIF, which is a extension of what Ayush just talked about, which is OLIF 2 to 5. So approaching L5S1 requires access through the bifurcation of the great vessel. And in minimally invasive surgery these days, it's done in a lateral decubitus position, exploiting that anatomical window. And it's done through a small incision in the left lower abdomen. Here's a video of lateral ALIF that I presented earlier this year. This is a video discussing my lateral ALIF L5S1 technique for a patient who has long-standing L5S1 spondylolisthesis due to a bilateral pars defect with a dysplastic sacrum.
The voiceover we cannot hear, Choi. We cannot hear the voiceover. Can you?
Oh, so you can't hear, you didn't hear the description?
Voiceover. The video is
No.
playing.
Maybe you can
Okay.
pause and you can give a voiceover now.
Okay.
Exactly.
So this is the approach. Just before you saw the incision planning, the line is a sacral slope line and an L5 end plate, and the incision is made about 3 to 4 finger breadth in front of the L5S1 demarcation in an oblique fashion, as you see there. The skin incision is roughly between 5 and 6 centimeters in length on the left edge of the rectus. Once the incision is made, we expose down to the abdominal wall fascia, and we divide the abdominal wall muscles and get to the conjoint tendon and incise that by cutting a line in a line with the muscle fibers, and then we take a retroperitoneal plane over the abdominal contents and back towards the sacral promontory. This is all done with a gentle retraction and with the finger being a excellent dissector. And then you can use a swab stick to gently push away the peritoneum downwards, assisted with gravity. The beauty of having the patient in a lateral decubitus position is that their abdomen can drape down. As you can see in this patient, this video was taken with my meta glasses. So this is actual surgeon's view of the surgery. And so once I make my abdominal muscle wall divided and opened, I'm usually able to visualize the shiny peritoneal wall that sits directly beneath the transversus layer. All of these muscles are just gently divided. Even if they were like inguinal hernias or adhesions, they will provide a bit of challenge, but oftentimes it's easy enough to dissect, as you see here. I'm not sure if the visual quality is good enough in demonstrating the orange color of the retroperitoneal fat that's on view now. And then once that's achieved, the finger is used to just widen that space immediately below. And first thing one must do is place the lighted blade to retract the abdominal wall and provide a bit of tension. And then your surgeon's finger should feel the inner side of the iliac crest. And once you then reach the pulsations of the iliac arteries, you should be able to then find the bifurcation by tactile feel of the finger, the bifurcation window. Once that bifurcation window is then achieved and loose space is created, using the lighted blades, we're now under direct vision exposing both common iliac artery and vein, and you tuck the left side, the superior side, up and expose the bare window between the two vessels. Once that vessel has been retracted and the bare window is exposed and you have identified the medial sacral vessels, they can be ligated or cauterized, and then the specified retractor can be used. In this instance, I'm using a semilunar ALIF retractor with pin-based blade positioner, but you could use many other generic ALIF system to expose and hold the window down. Once the peanut swabs are used and the vessels are ligated, the exposure window is relatively large at L5S1. Care must be taken preoperatively to identify the fat plane and the presence of the bifurcation window on an MRI, and the ease of exposure can then be assessed. But here we are. The two blades are being used to expose that window, and sequentially I will start to place the retractor blades down, and they will have to be pinned to ensure that the left common iliac vein doesn't creep down during the surgery. The exposure takes, anywhere between 10 minutes to 15 minutes. And then the blade placement is crucial. Usually, a lot of these retractors have radiolucent body and the customizable blade length for each patient. So here's the first left common iliac vein and bifurcation blades going in to secure the L5S1 opening. The beauty of L5S1 lateral ALIF is that when you do this in a lateral position, because the gravity is assisting the peritoneal contents moving away from the surgical field, there's less chance of ileus postoperatively. And also with a smaller incision, their pain is much reduced postoperatively, requiring much less opiates, which also aids with the bowels and the ileus incidence. Otherwise, it's an identical operation to a traditional supine ALIF, as in it exposes the entire, 270 degrees of the disc with a circumferential release and significant distraction and correction of the segmental angle and foraminal height. Because the patient's soft tissues and perineural tissue that sits over the anterior disc has been now safely achieved, you can use diathermy to expose and cut down the annulus and start exposing the disc. Special mention has to be made around retrograde ejaculation risk in male. As you saw before, at the initial dissection, minimal usage of diathermy and bipolar and swabs are recommended as the retrograde ejaculation from pelvic splanchnic nerves a real entity that occurs if they're not respected, and the incidences can be anywhere between 0.4% to 20%, depending on what literature you read. But basically, with very careful use of peanuts and bipolar and not using monopolar cautery, you can have very little or no incidence of retrograde ejaculation, even in young men. But as a routine, we always describe that and consent patients with it. And any young males expecting to have children, we ask them to have semen stored with the IVF bank, at least locally here in Australia, prior to the surgery in the event of a retrograde ejaculation. So here I am securing these pins. I do it under X-ray to make sure that I am catching well above the end plate and the pins are being anchored into the L5 vertebral body. So as you can see, my radiographer is now being positioned, and you can see that patient with the stimulator in with a relatively large abdomen is being now exposed as per our case description. And here you can see that the initial left blade is being positioned and being anchored. Once the position is satisfied on the X-ray, mallet is used to secure the left pin. You can have the option of both securing both the L5 and S1 side, but I prefer the L5 vertebral body option as the sacral end tends to taper away and the fixation into the sacrum is not as secure. Using a body mount on the frame of the bed, we can then assemble the ring, and the ring is then introduced at 20-degree angle in line with the abdominal cavity, abdominal wall, which then are ideally positioned to allow the radiographs to be taken intraoperatively without obstructing the critical view of the L5S1 disc during the correction of the surgery. This particular device is from Nuvasive. I understand that it's not available all throughout Asia. One of the key advantages is a very, very great lighting that it affords, and 4 degrees of freedom it has at the angled blade interface with the handle, and then further degrees of freedom at the attachment piece to the ring. So as you can see, this is all real time. We're just putting in the central blade to get the bifurcation blade set. And again, this is performed under X-ray to secure the central blade at the bifurcation within the L5 body. And the pin is positioned and anchored in and tightened by turning. It has threads on it that is now locked into the frame and tensioned to allow opening of the wound, and then anchored down and locked down at the fixed angle. Now with the reverse blade on the bottom side, we're now able to expose the entire width of the disc, just however on the lateral decubitus position. There through the window, you can see the bare L5S1 anterior annulus. And then we'll now start to perform the discectomy. And annulectomy will be the first step in sizing the annulectomy window, and that'll be governed by the largest cage that we can place through the bifurcation window that we have available. Oftentimes, it's somewhere between 34 to 36 millimeters in width. And here you can see some eye shots of the left pin and the central pin being positioned on the L5. And here you can see a close look at the L5S1 disc space with the central mid-sacral veins running across from left to right side of the screen. And the inferior blade tucking the right side common iliac vein and artery, which are never really on view. It really is a bloodless surgery as long as you don't create one during the surgery. And it's very elegant, much like Ayush's OLIF approach video that he showed for the upper levels. And the beauty of the surgery is that patient is already in a true lateral decubitus position to facilitate multi-level segment correction of the lumbar spine. So patient won't have to move, X-ray don't have to move, and you just simply move on from this 5-1 position up to 4-5 and then beyond. Particularly useful for multi-level degenerate scoliosis and multi-level deformity cases. Annulectomy is being performed after clearance of the mid-sacral vessel and exposure having been achieved. A knife is used to incise into the annulus, and then sequential clearance using shavers, pituitary rongeurs, dilators, and curettes and end plate can be then scraped off using rasps to prepare for the fusion bed. I mean, really, the surgery is very, very elegant and quite straightforward. The approach is really the key. I would advise surgeons getting into this operation to team up with a vascular surgeon initially, and to understand the vascular approach and the access prior to doing the surgery yourself. Here's cob work just to release and to make very efficient release of the subchondral bone with disc removal. I wonder if I can speed this up. Maybe I'll just skip a bit. So here's a pituitary, and there is the intraoperative window of the disc preparation. You can see a very clear, clean subchondral bone having been exposed and freed up. You can see the left vessel being tucked behind the left blade, and the bifurcation blade pinning the mid position, and then the right inferior blade exposing the bottom side with a clear view of the posterior annulus on view in this zoomed up picture. And you can see it's just completely bloodless because much like an ACDF or any other interbody operation, so long as you respect the plane of the anatomy and get the right plane for your disc preparation, it can be a very, very elegant surgery. So once that has been completely cleaned out, you can take down the annulus if you had a disc fragment that you were checking, clearing, and decompressing the nerve root. Here is an initial impaction of the anterior cage. Then you sometimes need to rotate and advance the cage further. I'd like to use an integrated cage because of a fixation into the end plate that secures the depth of the cage. But in cases of spondylolisthesis such as this, I'd like to not anchor the L5, as I will use the posterior pedicle screws to correct further and reduce the spondylolisthesis using compression and reduction technique. So only a single fixation screw is inserted usually into the sacrum or the L5. But in this position from the lateral decubitus, S1 is well situated to be my preferred fixation, as the incision and the wound well caters for that sacral slope angle to get an ideal 40-degree trajectory into the sacral end plate. My preferred graft and the interbody option is a 3D printed titanium with a simple synthetic bone graft such as calcium phosphate putty. I find really DBM and all these other biologic grafting option is unnecessary when you're using porous 3D printed titanium devices. They really do rapidly integrate with the end plates as long as they're prepared properly. And they achieve a very fast fusion, as demonstrated in multiple literatures, including our own experience that we published many years ago. So hopefully the video will end very soon with the single fixation in the sacrum. Yeah, and then initial fixation has been now achieved, and then later posterior pedicle screws to then reduce. And you can see that the cage has to be really seated quite far back because once the L5 migrates back during the reduction maneuver, the cage will look like it's meeting at the anterior part of L5. But if you look at the radiograph here, the sacral lip is actually much more forward, because that's how long with the dysplastic sacrum, this patient's L5 have been sitting forward for a very long time. Thank you.
Thank you, Choi. Only a quick couple of questions before we move on, and we can have more discussion during the case. So, how many levels normally you can get from lateral anterior? Like, can you do? I understand 4-5-5S1 is absolutely fine, but how many levels normally you can get it with the lateral ALIF?
I think that's it. With the lateral ALIF, you can really only get at 4-5 and 5-1. And in some bizarre transitional levels, you can get down to deeper transitional sacral levels. Key thing with these are the vascular window. So if the vascular anatomy allows for lateral ALIF over the OLIF and it's more favorable, then you would do this operation over the OLIF you just showed. And the other thing is the sacral slope must be measured on a lateral X-ray or a CT scan scanogram to make sure that it's above the pubis. So you draw an extended line from the sacral slope angle and make sure that extended line sits above the pubis. If it is below the pubis, then you basically end up making an incision in their groin and you may not be able to get any instrument in there. The exposure may be feasible, but the instrumentation and angle devices are not available to facilitate that surgery. So XALIF is really just for 5-1 and 4-5, and in occasional instances S1, S2, if they're favorable, but definitely not above that level. There's a better operation, which you just demonstrated, ATP or OLIF approach, which doesn't require any vessel mobilization and not even on view. So I would stick to those.
Okay, great. So let's have more discussion when we discuss the cases. So I think Dr. Park is here. Are you there, Dr. Park?
Yeah, I'm ready.
Yeah. So thank you for joining us. And next we have Dr. Park from Korea, and he will be talking about UB TLIF, which is again a very, very popular technique across the globe and becoming more popular every day. So over to you, Dr. Park, and thank you for joining us.
Okay, wait a minute. Okay, thank you, Chairman. Yeah, thank you for inviting me since this webinar. I will talk about biportal endoscopic lumbar interface fusion using multiportal technique for large cage insertion. Okay, as you know, the biportal endoscope technique has been established as an alternative to microscopic surgery through many studies, including my IST study. In particular, because it provides a more flexible surgical view and instrument movement, it has the advantages of both endoscopic and open surgery. Based on the disadvantage, we are trying to expand the indications of biportal endoscope technique to TLIF surgery as well. Biportal TLIF has two approaches, the conventional posterolateral TLIF approach and the extraforaminal approach. The extraforaminal approach allows the more lateral access. It can make the large cage easier to insert as well as more correctly placed. In order to insert a large cage, I prefer using the multiportal technique. By adding a medial portal, sufficient contralateral facet removal can be performed for more optimal harvesting and increase the facet mobility. And then two additional portals are created approximately 2 centimeters lateral to the pedicle to allow for the correct insert of the large cage. These portals can be used for pedicle screw insertion later. First, confirm whether the patient needs the contralateral side decompression. If contralateral decompression is necessary, two medial portals are made just lateral to the spinous process to perform the central and contralateral decompression. For patients who do not require contralateral decompression, two portals are immediately only correct about 2 centimeters laterally to the lateral margin of the pedicle. And then after finding the facet joint, perform the full vasectomy and hemianopectomy by removing the SAP first, followed by the IF and isthmus to make space for insertion of a cage. Let me show the video clip. The right side of the screen is the cranial, and the left side is the caudal side. When approaching from the right side, first assess through the medial portal to find the facet joint and begin central decompression with a chisel and cast punch. And superficial, the ligament flap is removed and the bone is done, the ipsilateral side. Then moving along the west of the spinous process to the contralateral side, perform the decompression and release the contralateral facet joint. To prevent dural injury during the bone work, I recommend you should avoid performing ligament flabectomy until exposing the dura, and then check the full bone work is done. Next, the facectomy is performed to make adequate space for cage insertion, followed by a foraminotomy to decompress the external root. This is achieved via an extraforaminal approach through the lateral portal. Decompression and ligament flabectomy is then extend to the contralateral side. Ligament flabectomy, entire ligament flabectomy is done to the contralateral side. And check the complete decompression, contralateral side and ipsilateral side. And then the preparation for cage insertion is complete. After total facectomy and discectomy is performed once the tremosing and its root are clearly identified, aneuratomy is carried out using an Indian knife, like this photo. And then the followed by the disc removal with the serial reamer and end plate preparation is now achieved, which is one of the major advantages of bipolar SMISS-TLIF. Finally, a funnel is inserted and the bone graft is performed. In my case, I used to use a regular sized curved TLIF cage, but now I'm using a large size 3D printed porous cage to increase the union rate. After inserting the cage, change the direction of the impact to lay the cage horizontally. It seems similar to the OLIF surgery, which is known to offer good biomechanical stability. We now proceed the disc space preparation. The first one, the aneuratomy is performed using an Indian knife, followed by fascial discectomy with a pituitary forceps. And then the disc space is gradually widened with a serial dilator while removing the disc material. After mexical disc removal using an angled curette, the viewing portal is switched to the medial portal to inspect the superior and inferior end plate. Once the end plate preparation is complete, autologous bone is then inserted through a funnel, and then the cage is carefully placed under the sham guide. Using an impactor through the medial portal, the cage is positioned transversely. And finally, the remaining autologous bone is packed to complete the fusion. Finally, after percutaneous pedicle screw insertion, I use a long sleeve compressor to reach the screw head. It can create more resistance than the conventional instrument. Let me introduce my case. At the first case, a 66 years old male patient who underwent extensive laminectomy at 345 S1 10 years ago, complained of latent pain in the left lower leg. He also complained about severe urologic claudication. In this patient, direct course was necessary for the lateral recess, the epidural fibrosis, and the foraminal bone osteophyte. In addition, there is a high possibility that approach is hindered by fibrotic scar on the posterolateral side. I plan the extraforaminal approach to avoid the previous scar region. This is the left side extraforaminal approach. First, we identify the tip of the superior process and perform the vasectomy and foraminotomy. The first SMISS-AP, the resection. Okay. Identify the existing root. Skip the video. Confirm the existing root is free. We wide the operate field by additional isthmus resection, and vasectomy and more regard phlebotomy. Once enough space is secured for cage insertion, we use the instrument to prepare the end plate, the similar with the previous video. Okay. Okay. Before the cage insertion, we create the additional medial portal to change the viewing angle. This allows the cage instrument and camera to avoid the interference while providing a better working angle. After the cage inserted, I adjusted its position through the vertical portal to achieve the final placement. Okay. After performing the directed compression by extraforaminal approach, a large PICC cage was inserted. Following the surgery, the patient's previous foraminal stenosis was resolved. During the perioperative period, the patient's operation time and range were within normal limits, and no transfusion were required. This is a second case, a 76 years old female with a 3 years history of posterior lower back pain and left leg radicular pain and neurogenic claudication. She revealed the left foraminal stenosis accompanied by the central lesion. As direct compression was required, we planned the TLIF surgery using a left side vertical technique. Left side posterior approach is left side posterior approach is used to perform ULVD, achieving decompression of the central canal. Bone up, so it's tended to the contralateral side. Contralateral side decompression. In this step, the full procedure is performed via ipsilateral approach using the two medial portal. After central decompression, the lateral approach is used to perform the vasectomy and the foraminotomy, creating the space for cage insertion and decompression the eastern nerve root. And then the recurrent phlebotomy is then performed, achieve the complete full root decompression, including the contralateral side. Where the compression to check the contralateral side and lateral side. And then the disc space preparation is performed when the scope is inserted through medial portal, shown here. Better visualization is obtained. You can check the superior and inferior end plate. Okay. Finally, the cage is inserted through the adequately prepared space, as shown in the previous video, and positioned horizontally. Okay. After performing direct compression by posterior approach and the large 3D printed cage was inserted by extraforaminal approach, following the surgery, the patient's previous central and foraminal stenosis was resolved. During the period, the patient operation time to 175 minutes and drainage was 126. no transfusion. Take-home message, bifocal induced lumbar antibody fusion with a multiple technique could be a good option for placing a large cage correctly. Using additional media filter allows a better decompression and proper cage placement. In foraminal stenosis case without the central decompression, the extraforaminal approach could be a good option. Thank you.
Thank you, Dr. Park. Excellent technique. I just have a couple of questions to you. What is the normal length of the cage you place when you are doing these big cages?
Why? Sorry.
What is the length? The length of the cage.
Length,
What is the
length.
average?
Yeah.
Yeah.
40, and 42. 40 was 42.
Okay.
And the width is the 13.
Yeah, I got it. And do you find ever you have a, like, maybe you are sometimes unable to rotate it completely? Does it happens to you? Or are you able to place this perpendicular every time?
No. Yeah, it's not easy. Yeah, to the horizontally, the correctly. Yeah, so sometimes the oblique insert in cage. Yeah, but I think it's no matter. Yeah, I want to the place on the up pigeon ring. Yeah, because it's for the biomechanical stability. Yeah. So
Yeah, I agree. I think these big cages do have their advantages. How you place it, and if you can place it through UB, I think it is an excellent technique to do. So I think we can discuss more when we go through the cases. Gururaj, do we have you? Is Guru
Yes, I'm
there?
here.
Yeah.
Yes, I'm
Oh,
here.
okay.
Just sharing my screen.
Yeah. So I think it's time to implement how the different techniques can be used, or what is the pros and cons. And I think over to Dr. Gururaj for the first case presentation.
Okay. Once again, thank all the speakers for being here. So let's see with the case example uh, where exactly all techniques can be applied. I have two cases where we can discuss what technique has advantages and what does have basically some disadvantages. So, okay, that's the first case. 1 minute. Okay. That's a 28-year-old male patient complaining of right lower limb radicular pain since last around 1.5 years, but it's severe since last 11 months. Occasionally, he has tingling and numbness, claudication pain, walking distance is less than 500 meters. Pain increases on movements, especially on forward bending and sitting, decreases only on supine position, and it's gradually progressive, no comorbidities. Neurology, he has a mild L4 weakness. Rest, everything else is normal, and heel walk is not possible on the right side. So that's pretty straightforward. A grade 2 progressing mildly in flexion. So a lytic listhesis with sacralized L5. So L4-5 grade 2 spondylolisthesis. That's the MRI. You can see that there is a pseudo disc bulge with foraminal narrowing, and that's axials. That's the CT. That's the CT. Okay, so anybody wants any other information? We will discuss the management after the second case I present. But then anybody else wants any other information on this case?
I think you have put everything is pretty young.
Everything.
So
Yeah. So you can see the CT, bilateralizes, big gap, big slip, decreased disc height. Okay, so next is the extremes of another age, that is 71-year-old, back pain since long time, but severe since last 6 months, complaining of claudication on bilateral lower limb with right lower limb radicular pain. Again, progressively, the walking distance is decreasing and increases with activities, relieved with rest. and no paresthesias, no upper motor neuron signs, known case of asthma, and neurology pretty much normal. That's her X-ray. We can see in AP there is some fascicle arthropathies. You can see mild slip in flexion extension at L45, and that's again her MRI. Sorry, we skipped. That's her MRI. That's at L5 as well. Okay, now we have all these four approaches. So let's start with Arvind. Arvind, are you there?
Yeah, so for the first one, I would vouch for both MIS-TLIF or OLIF, because there's no much canal work to be done there. You just actually have to stabilize the patient. You need to just fuse
No,
it.
no,
So
no,
your
Arvind,
approach,
Arvind, let's do one thing. Like you do MIS-TLIF, why will you do? Why not ALIF or OLIF? Or if you do OLIF, then why will you do? Why will not do other
yeah.
techniques?
See, this is a great case for OLIF, the first one, because you don't have to
Yeah.
do any canalicular work. So you basically have to free the foramen. You have to jack up the disc space. Your eyes are on the disc. So OLIF is the right approach for the first case. And for the second, I mean, of course, it can be done from behind also. The advantage being, you can distract and open up the disc space, put in a cage, and then compress. You can maneuver with the pedicle screws and get the same degree of correction. And you can probably get to see the root also, which OLIF may not allow you. So that is an advantage of MIS-TLIF. But I think both are equally good options. But for the second case, I would do a MIS-TLIF because there needs to be a lot of intracanalicular work done. So you need to decompress the roots on both sides. I'm not sure how much of indirect decompression you will get. Flexion extension X-rays do not show much mobility there. So I don't want to burn my fingers and do a decompression again. So I'll do a MIS-TLIF in the second case straight away.
Okay. Ayush?
I think both the cases can be done OLIF or MIS-TLIF. Okay, you just I think both are there's of course OLIF for me is slightly less minimally invasive, and especially the pain and everything, in at least in my hand, maybe with others it might differ, is slightly less to the patient when I do them. So I think the indirect decompression will work even in the second case based on the experience we have. Once you, if you can get it right, as the case I showed you, it was worse than the case you have with you. Only thing I will, in the second case, I will also look at a DEXA, especially when I am relying on a big cage to jack it up, because if the DEXA is poor and I lose my cage to the end plate, that is the end game for OLIF, because you are relying completely on those end plates to jack the cage up. Otherwise, I think whatever you are comfortable, I am more comfortable with OLIF, so I will prefer the OLIF here.
So when will you not do OLIF in such cases, Ayush?
So see, if you have a significant deficit, you cannot rely on OLIF to do your decompression. Then I will need to do a direct decompression. And this is my significant deficit is 4 plus. I don't consider it significant deficit. But anything below 4, you have 3, you have some a foot drop. I think you cannot say ki I won't see the nerve root. That is what Dr. Arvind Kulkarni was also pointing out. I will definitely need to see those roots. This is one place I will definitely not try not to do OLIF. Other thing is, if you have made more than grade 2 listhesis, which is not correcting on your positioning, again, those cases you can do OLIF, but it becomes slightly challenging. You are guessing a lot of things because of the anatomy slightly changes if they are more than grade 2 listhesis. For me, these, and then of course, if on the axial cut you have a anatomy which doesn't support your corridor, which is the anatomical corridor for OLIF. So these are the basically 3 indication where I will avoid doing OLIF.
Any others, Dr. Choi and Dr. Do you have any comments? before
Jacob
we
and
proceed?
Choi.
Yep.
So for me, indications for OLIF are similar to Ayush, except I guess the question is when to directly decompress. I directly decompress if there's a space-occupying lesion, such as a facet cyst or calcified mass, or a hard calcified disc at the lateral recess. Most of the foraminal pathology, other than a extruded disc, can be achieved if you were to do a fusion with the OLIF. Don't forget that all of these methods that we're talking about are fusion methods, and if it obviously can be done without a fusion, then that's obviously less invasive yet again. So that's the only caveat that I'll add here.
Okay. Doctor, for UB, will you do UB
Dr.
fusion
Park,
here?
Dr.
Dr.
Park
Park?
just left. He had another meeting,
Okay.
so
Okay,
we can ask Jacob. He does UBA also,
Jacob.
or he can go. Does he prefer OLIF?
Yeah, that's
or-
thanks. That's a great case. You know, for the case number 2, that's the kind of cases that I wonder whether, when you see OLIF, I like to do an OLIF when there is a spondy, a very clear spondy, and a loss of this height. For case 2, the height is quite preserved and the spondy is mild. So I worry sometimes when I put an OLIF cage, I'm swapping the disc for a cage. And I wonder how much indirect decompression I can achieve with this. And so I really need to ask the patient when they lie down or when they sit down, does the pain go away? Because if it doesn't, then I will have to do an OLIF, then I'll do an OLIF plus a direct decom. Otherwise, I think an MIS-TLIF will be just as efficient. For the first case, you know, it looks, my concern with that was that the listhesis, the grade of listhesis is quite high. So I asked myself, can I actually fit a cage in between that overlap, right? Because an OLIF cage can be quite wide. And if you cannot sit the cage in nicely, the landing zone might be quite difficult. Fortunately, and this is what I always look at, the MRI scan shows that when the patient lies down, it reduces quite a bit. Sometimes in flexion extension view, because of pain, they don't move as much as we want to, but when they lie down, you can see it corrects a little bit. And that gives me a little bit of reassurance that there will be a space for me to put the cage in. Although I will probably have to aim for a slightly shorter width cage, like an 18 mm rather than a 22, right? And then I'll probably flip the patient prone and then reduce it as well. So for the first case, I would say most likely is an OLIF. For the second case, OLIF with a direct decompression if the symptoms doesn't go away when they're lying down, or a TLIF. But I think in either way, these patients will do well if the procedure is done right with the surgeon's experience as well. Nice cases.
Yeah. So okay. So let me proceed. So yes, typically I would do, because I don't do endoscopy fusions. I do both OLIF and the ALIFs and stuff. So at L45, ALIF is going to be difficult. Otherwise, because in first case, we have to reduce the listhesis also, as Dr. Jacob pointed out. If you don't reduce it before you place your cage, you will have to put a smaller cage. Or when you jack up your disc, if it reduces, then you will be able to put a larger cage size there. But then I want to utilize the advantages of an ATP approach with the simplicity of the MIS-TLIF, with intraoperative manipulation of the listhesis, if at all, if I want to do. So I want to do a single position surgery. Yes, we, with the navigation and robots being available, we can do the same thing with OLIF and placing screws and reducing the listhesis and then putting our OLIF cages also. But then what I chose is the simple approach here, that is the KLIF, that is transcambin fusion, because this surgery is done in prone position. especially in listhesis case, there you can put your screws on the opposite side and manipulate the listhesis a bit, and then you can place your cage through a transcambin approach by distracting the cage also. So typically for beginners, this fusion is done through posteriorly by paraspinal corridor through the cambin triangle, and so this is how you basically approach between the exit and the traversing route. And I did this through a robotic planning. You can see this, my guide wire placement planned through the robot. And that is the planning was done for the second case. And that's the steps for the second case where we placed our guide wires first and then did the interbody work. And then you can see that listhesis is reduced and we have placed a well-placed cage. And the second case is this. So any comments from Arvind, starting from Arvind?
This
So
is
this
the
is a
first
new
case or the
technique.
second? This is the
This
first
is
case or the
this is
second?
first case. This is first case.
First case.
This is the
Yeah.
second case. Yeah. So this is the first case where L5 is sacralized and we have reduced listhesis almost to the zero and placed a very good size cage, and it was done completely through a minimal invasive approach. You can see we could achieve
So
some
where did
lordosis also.
get your bone graft from?
So basically, in this case, I used a lot of Glex putty with DBM. So I've not used any autologous or allograft.
So, and the other thing is this cage. So, I mean, I can understand it looks reverse lordotic because the nose is in the front. I understand it because it has to enter in, but the posterior can be still a bit lordotic, right? Man,
No, the cage is posteriorly lordotic. If you see this cage here, you can see that the only nose is pointed, but rest this portion is bigger than the posterior portion.
it looks good, except that the cage can be still more lordotic.
Okay. So Ayush, any comment on this technique?
So, every technique is as good as the
Because
surgeon can
this
do
is
it.
a
Yeah.
battle of
Yes.
techniques. So ultimately, I
Exactly.
wanted to present one
So,
more technique
yeah,
where
exactly.
we can
Yeah. So
manage these cases.
yeah, I think it looks good. Only the jury will be out there how well they fuse and how the long-term results are there. But on the face of it, what you have done looks acceptable. But only thing
But
we
what
have
do
to
you,
look.
Ayush, what do you use in OLIFs? What bone graft do you use in OLIF?
I use calcium silicate mixed with bone marrow, which I find is the best. And for multi-level, I use BMP. So more than 2 or 3 level, I prefer BMP where I divide one BMP into 3 levels. But up to 2 level, I use calcium silicate mixed with bone marrow, which I have found to be very, very good, at least in our hands.
How about Jacob?
Yeah.
What do you use in OLIFs when you're not harvesting the facet joint?
Yep. Great question. For OLIFs, it depends. If I'm using a peak cage, I will use DBM plus or tricym phosphate with BMP. I always put BMP if I'm using a peak cage. But if I'm using a metal cage, they fuse really well, great integration. Then you can easily put anything you want inside down there. So I've been using just DBM, no BMP. So I think it saves money if you put the metal cage. And I learned this from John Choi.
Yeah, I don't use BMP. I don't use DBM. I don't use allograft. I just use biphasic calcium phosphate. In the market, it's called Magneto, so it tracks. It's basically HA with tricalcium phosphate. It's a submicron needle shape graft, and it fuses like very, very well. And it's not really about the graft so much. It's about the topography and the nanostructure of the 3D printed porous titanium that actually makes the difference. And because the OLIF cage has such large surface area for bonding, with the end plate. It achieves better results than had it been used with a TLIF, but this looks fine. I think this is acceptable, and I think this will go on to fuse well, I would think, as long as the device is good. The reduction looks excellent. I think the patient has had very long-standing listhesis, so the end plates are very abnormally shaped. And it would have been a very challenging reduction, but they've done a very good job here.
So that is why this approach I use typically, because I thought if I'm not able to just jacket up the disc, so I can use screws on one side and try to manipulate the disc and then try pushing in my cage. So actually it did reduce a bit, and then I put in my screws on the opposite side, distracted a bit, reduced a bit, and then did an interbody work from the opposite side, from the left side, and then finished this work.
Guru, since you
I
are
would
not
say, one thing I would say
Yeah,
is, as a technical tip, if you're doing OLIF for this, is to reference all your work off the caudal vertebrae. So you have to do your initial docking, initial retractor placement, initial dissection, and everything off the caudal vertebrae, and aim for the 50%, 30% of the lateral disc of the caudal vertebrae, and ignore the cranial vertebrae, what it's doing. Because during the sequential distraction and clearance of the disc, you'll start to manipulate the cranial vertebrae, and it'll come to reduce automatically, because that's the function of the facet joint, whatever hypoplastic they are, and that'll be the function of the PLO, which is intact.
And best part of this technique is once the guide wire is in, you have this dilator, which smoothly slides onto this sclerotic end plates and really helps in getting the disc space height. So that helps you in getting the disc space height and locking that disc space there and getting a good size cage there. Because these are all pointed nosy instruments, including the shaver, including the sizer. They all help you in distracting the disc space without damaging your end plates.
Guru, since you are not exposing the roots, does it make a difference whether you're going from the symptomatic side or asymptomatic side?
It really doesn't matter. It really doesn't matter. It really doesn't. So the main aim is, like we all know that in lytic listhesis, we have to achieve the disc height and reduce the listhesis. So ultimately, that takes care in 99.9% of the patients, until unless patient has deficits or a root is tethered there. So,
which is very unlikely in lytic listhesis.
Yes, it's very unlikely. So that's why I feel this ALIF approach, that is transcamin fusion, actually it combines some advantages of ATP and some advantages of MIS technique, where you do it in single position. You can use your screws also to do some work. So that's why I prefer, when I feel that only OLIF is not able to do the job, I would prefer to do this sort of job. Thank you.
Thank you, Guru. Moving on to Jacob, who is the last batsman for the day, and he will have multi-level, pathology. And let's go over to Jacob.
All right, thanks everybody. It's been a great session, and it's so nice to hear from all these wonderful talks. So I try to find a case that everybody can have a go, can do a TLIF or a KLIF or a ALIF as well. So this is a lady who is 55 years old. I operated on her before for cervical myelopathy, and now she comes in with severe back pain and leg pain. I would say that she's got more unilateral leg pain, but she's also got back symptoms. And she's walking for about 30 minutes before she needs to sit down, and she's tried everything and she wants something to be done. She's neurologically intact apart from the claudication. And these are her x-rays. And I think you can tell that there's severe disc height collapse at L34, L45. L5S1 also height is a decrease. And this is an MRI scan. Big disc herniations at L34, L45, and also L5S1. And on the axial cuts on your right, you can see there's severe stenosis at this level. There's a nice corridor. I know Ayush is looking at the psoas already, and the psoas is quite favorable for him to do something. I want you to draw your attention to L5S1. While the stenosis, central and lateral recess isn't so bad, there's foraminal stenosis at L5S1. Is this severe enough for you to tackle this one? Will you just do a 2-level, something that we can discuss? But there is modic changes as well. L2-3 isn't so bad, but there is a disc bulge and there is some degenerate disease.
Anil Pani.
And then now you can see the CT scan shows gas at all 3 levels. And also take note that L2-3, there is an osteophyte on the lateral aspect as well. You talk about deformity. Actually, there's no lesion on the flexion extension view. And if you look at the pelvic parameters, she's got a type 1 Ruzuli curve. PI is not very, very high. So her lordosis kind of matches it about within the 10 degrees, if you believe in that concept. But SVA is less than 5 and the BMD is -1, so not too bad. So over to the esteemed panel, how will you deal with this patient? Will you do, how many levels? Will you do 2 of the worst levels, L3, 4, 4, 5? Do you think L5S1 foraminal stenosis is bad enough? Will you do 3 levels or will you do 4 levels given that L2-3 has some signs of degeneration? And how will you do that? So shall we start off with, since we started with Arvind just now, I want to start with Ayush.
Yeah. So basically, see, for me, it's a multi-level pathology, okay? And if the corridors are good, it always makes sense to go for OLIF. I think, it is the easiest thing you can do. You can tackle all the levels. And one thing, 5S1, I will really like to see if we need to do. Do you have the axials for 5S1 as well?
I do. Let me just show you the L51.
Okay, I think it's pretty good. I think it's a very ideal case to tackle all the 3 levels in lateral position. And I think only thing more I will do is get a DEXA to see how good the bone quality is, because especially when I'm doing multi-level pathology.
-1.0. Not too bad.
So I think a very, very good and ideal case for me to do all the 3 levels with lateral position OLIF.
Okay. How about Guru?
Okay, so yes, when I see the central canal here, I'm very much tempted to do a 2-level MIS-TLIF. But then because I see that the disc sites are very, very less, and I'm encouraged by seeing that the DEXA is not very bad, we can do a L3-4 and L4-5 OLIF. And maybe I would repeat an MRI and then see how much is the decompression happening at L3-4, L4-5. And then I would just do a L5S1 lateral recess decompression. I won't fuse L5S1. So I would just fuse L3-4, 4-5. And L5S1, I would just do a lateral recess decompression.
Okay. How about the foraminal stenosis? Will you tackle them?
So the thing is,
you think it's bad enough? Because sometimes the radiologist is bad,
but it's not that bad enough. Because if we take maybe 1 cut before and 1 cut after, I think should be fine. And axials, it doesn't look very bad. So I think L5S1, we can just do a maybe tubular decompression or maybe a central decompression. That should be enough for L5S1. So I wouldn't fuse typically L5S1 because if I fuse L5S1, I think L2-3 is going to go down the lane very fast. So I would like to leave that L5S1 disc mobile, considering their age also.
Okay. Then I'll ask Arvind next. Arvind, will you do 2 levels? Will you do 3 levels? MIS-TLIF? I was looking at L5S1. There's a bit of gas and she's got symptoms on the left leg. Do you think that foramen, will you leave that foramen alone?
Yeah. Can I know the history of the patient? Sorry, I did see,
The,
but
pa-
still, what
the
is the age of the
patient's
patient?
she's 55 years old. The main problem is leg pain,
Oh,
but she's
okay.
also got back pain. But the leg pain is mainly on the left side, L5
Yeah.
distribution, which
Yeah.
kind of correlates to this
Sure.
L4-5 lateral recess and the L5S1 foramen.
Okay. See, basically, I'm not going to get influenced by fusion here. I do a lot of hybrid surgeries. So I don't think L4-5 is unstable, and L3-4 I will have to fuse because accessing the disc would be difficult without excising the facet. So I'll do a L4, L3-4 TLIF, MIS-TLIF, L4-5 decompression. I'll not pay any heat to the L5S1 foraminal stenosis. There is a good paper which shows that if we have a vacuum phenomena and if the root is at the level of the disc, so then it is significant at L5S1. The root has to be, here the root is above the disc. So, so many times we have L4-5 stenosis, and there are also some foraminal stenosis at L5S1. You're always anxious, that this patient may be having an exiting root issue. But I'm not very impressed with this. If there is good amount of vacuum and if the root is right in front of the disc at L5S1, that is when I would be anxious and include that. So I'll do a hybrid L4-5 decompression, L3-4 TLIF. And I'll also tell you whether you do this or that. This may not be the last spine surgery of her life.
Yep, that's a good point. Yeah. Guru, you got something else to say?
Yeah,
Then
so
we'll ask John
that is why I said when we do this staged OLIFs, that will help us in deciding also whether her radicular symptoms are gone. So if she doesn't have any radicular symptoms, then you can just leave that part off and then just do a percutaneous pedicle screw fixation in second stage.
Okay.
So yeah.
John, what's your take on this?
Yeah. Before I give you what I would do, just on Guru's comment, I don't know how long you leave in between stages to decide on your posterior over the after the anterior, but 1 or 2 days isn't really an adequate test to see if the leg pain is gone while he's an inpatient getting post-operative pain meds, and discrimination of leg pain immediately after surgery, I think is an unfair test and unreliable to do. I'm kind of like in agreement with Kulkarni because the L3-4 on the CT scan looks like it's completely collapsed, and it almost looks like it's not that mobile. Whereas 4-5 and 5-1, I think, is definitely very mobile. And given the patient's symptoms are predominantly leg pain and claudication, and there's no frank neurology on examination. And as again, Arvind pointed out that at 56 years of age, with all the degenerative changes, including L2-3 starting to go, this will not be her last spine operation or spinal problem. So I'm very, very conscious of ASD and other problems we'll create for surgery in itself. So my assessment is I'll do 4-5 and 5-1 fusion, correct her alignment, sagittally at least, and stabilize it. Set the L3-4 on a good foundation to neutralize everything, and then I'll decompress L3-4 endoscopically, and then percutaneously put instrumentation from 4-1.
Okay. That's interesting, John. It's very interesting.
So four surgeons, 4 surgeries.
Yeah, you know what?
Yeah.
Because so you're saying you're gonna fuse 4 to S1, and then we always fuse 4, and then we always worry about the level above. If it's healthy, we will leave it alone. But now
No, I'm the opposite.
It's this modic changes
there
as
are a
well.
lot of papers that show that PJK, PJF, ASD is at a highest when you end your construct below a normal level on an MRI. And mid-lumbar spine have high flexion extension arc. and in this patient, ending your construct at 4 and leaving a 3-4 very stiff disc to be stiff and perish will actually auto-protect L2-3 further and give it longevity. And given his 3-4 problem is predominantly stenosis, I would definitely decompress because that's his, that's her primary symptom generator. But I think I would need to fix the 4-5 and 5-1, which presumably either led to 3-4 problem or preceded the 4-5 problem. I don't know, but basically I want to do everything I can to avoid a fusion at 3-4 and 2-3.
Okay. So she's got back pain, and then from this scan, I mean,
Yeah,
I
I think she's gonna have back pain, whether you do 1-level fusion or 4-level fusion or no fusion. She will continue to have back pain.
Okay.
Yeah, and
yeah,
I think big correction in the bottom would help her a lot with the fusion back pain. But you're never going to be eliminating her back pain. Yeah.
Okay. Interesting. Because I see some cysts down there and some it's like there's gas and so sclerosis. It's a classic thing that you look in an OA knee, right? And I'm surprised, but yeah, look, makes sense. She doesn't have a spondy down there. It may be stable, right? And she may get problems later on top.
Yeah.
All right. So 4 different opinions. Wow. Okay.
Yeah.
Okay. So what time is it? So in the interest of time, I should tell you what
Very
I did.
interesting case here.
Okay, so I did this, right? I did a full MIS approach. We had my big problem was
One
really,
ALIF, 2 OLIFs.
yeah, 2 OLIFs and then
5-1.
2 OLIFs and a 5-1 ALIF. So we discussed her main symptoms was L5 root. So to me, that foraminal stenosis was relatively significant because it was narrowed, there was gas, and it was tilted to that side. So I really wanted to take away that pain, and her back pain was to her significant as well. So I treated all the levels. And so this is what I did. Just some intra-op photos. The marking was done as described. I start with the lateral first. And then after that, this was a invasive case. I do feel that invasive has a great 5-1 system as introduced by one of our colleagues here. He invented it. And then here you go. I do the upper level first, and I make sure I do a contralateral discectomy so that I can jack up the height well. Okay, and the cage goes in. These are the metal cages. And then I go for the next level. Again, discectomy, and then put the cages in. And you can see the height is increased. And then L5S1, going down to the...
It's going to be a height for that.
And then after that, here you can see the 3 levels is done. I try, all these are the shortest height cage because I don't want to put too much stress on that L2-3. And then that's how she looks like.
इसने भी एक ही screw डाला है हमारे जैसा.
And that's the view at the end of it. You can see.
वो ये लिफ्ट प्रेजेंट करना चाहिए अगले बार DSS meeting.
She ambulated on day 2, discharged on day 5. She's back to work after 1 year, and she's doing okay. This is 1 year, and she's just about to get her CT scan. With that, I thank you, and I hope to see everybody at the SMISS meeting this year. Thank you.
What did you do at the L3-4 level? There is a central stenosis with a big disc.
Yeah, that's a good question. I actually did a direct decompression for that.
You went behind later.
Yeah, I did. So I did a direct decompression at only, especially on the left side. Actually, 3-4, I didn't do anything. It's only 4-5 because she had 5 root symptoms. So I decompressed L4-5 lateral recess. Yeah.
But it looks like 3-4 facets are all gone. So you must have done a direct decompression there.
I did a few decompressions. I did this a while back. Yeah.
Yeah.
Yeah,
I
sorry.
think you've done I did both. 3-4.
Yep.
I think you've done 3-4 and 4-5.
You can't let go of that L3-4. It's very bad.
Yeah, it's very bad stenosis.
Sorry, both sides.
Yeah, I think he's done that because you can't see the facets anymore, and he's blown it all out at the back. So, yeah.
Yeah, that's
Yeah,
right.
only question is, Jacob, when we do this L5S1 ALIF with a good lordotic cage, uh, do you think your foraminal height further reduces with the lordosis which you create?
Um, I mean, it increases from my experience that it goes up. Do you find it gets worse? Your patients get more symptomatic after that?
Because if you see in the X-rays and all, still we don't see any like increase in the foraminal height there. At L5S1 especially, L4 and L34 definitely it has increased. And when I saw your sequential X-rays, I did see L5S1 disc getting jacked up a bit. But then when you put your cage in, it looks more lordotic and the height seems to be the same. That's the only observation. Otherwise, I think wonderfully done case. Yep.
John, what do you think about that comment? Giving more lordosis, does it narrow
No.
the foramen?
So go back to your intraoperative shot.
Yeah,
I
it
thought
did distract a bit.
Yeah, go
Yep.
just before it. Yeah,
Before this,
before it,
before this.
before there. No,
Yep.
there.
Yep.
And then put
Mm,
no, go back, buddy, where you were
No.
before, where you had the
There.
carbon there. Yeah, and then distract. I think there
Yeah.
is distraction there, definitely.
There
I
is
think
some distraction, definitely. But
I think the point
Dr.
you want to
Choi,
make, yeah.
Dr. Choi, do you think those osteophytes on the posterior vertebral body, when you
Mhm.
distract them without excising, they do
Mhm.
also pinch the root against
Yeah,
the
Are you
pedicle?
talking about
it
these folks
depends.
over here?
Yes. Yes.
It
Yes.
Those
depends.
folks.
Yes.
I think it depends. So if you're using hyperlordotic cages more than say 20 degrees or
Yeah.
20 degrees or more, you are under very high incidence of impingement of the foramen because of the angular change and the morphological
Yes.
change of the SAP migrating forward and then IAP migrating back, exposing the SAP tip towards the foraminal component of the nerve root heading out. So Jacob has cleverly put only a 10 degree or a 12 degree cage in there to prevent that. Had he went for much higher angle, then he has two problems to deal with. One, he has to go for much taller cage to get the foraminal height right, to get that cage in, which means he runs the risk of subsidence. Or if he uses inadequate height and then puts in a hyperlordotic cage, then he'll run into the exact problem you're mentioning, that you will create a new foraminal impingement from the end plate spur and the SAP tip hitting the exiting portion of the nerve root. But he hasn't done that. He's just done a 10-degree cage, which just expanded it from its native position. So he hasn't changed much of the angle of that level, which is the way to do for this case if he wasn't directly decompressing. But you're right, that's a very, very big caution. And when someone has a high degree of foraminal stenosis from abnormal change of the facet joint and SAP a morphological change, you must consider direct decompression if you're going to jack up that level, particularly with lordosis.
Guru, I think that point is when you're using even not just for 5-1, but also for other levels, if you're doing hyperlordotic cage, that is a problem because the posterior height can be quite short and that compresses it.
Yeah, but the problem is the opportunity to do hyperlordotic cage is the greatest at 5-1, and we often go for them at 5-1, and that's the point I think Guru's making.
Actually, if you go back to your post-operative X-rays, Dr. Jacob, so that's why I asked you is that if you just go back to your post-op X-ray laterally, if you zoom it up, you can see that there is some separation in the superior facet, which looks like it's jetting into the foramen there. So that's why I did ask that question. If you just zoom it there and see. Okay, Ayush, do we have time? We have.
Like we have almost finished, and
Yeah.
I think for the sake of the time, I think we can have your closing comments. But before that, I think great case. I think ideal case to discuss everything, all the techniques all together. So thanks, Jacob. It's amazing how 4 different surgeons can have 4 different opinion. And
I love
believe
these
me, I think,
discussions, right? So
yeah,
we all learn from every
yeah, and
every
I
aspect. The
think,
crucial thing is that we discuss and we know how to tackle the important parts that's giving them
yeah,
problem.
and it's amazing. And believe me, when everyone does the case, I think at the end of the day, the results is satisfying. It totally depends upon what is the technique you are good with, what is your thought process, and if you execute any technique, no matter what technique you're comfortable, the end point.
I think Ayush is traveling. We lost him. So at the outset, from MISSAB, I would like to thank all the faculties, Dr. Jacob, Dr. John, Choi, Dr. Park, Dr. Yong, and Arvind. So we will meet again for the next webinar, maybe coming in last again 3 months. So thank you, and maybe if some of you are coming to APSS, we'll see you there in February in Jaipur. Thank you all.
Thank you.
Thank you.
Thanks, guys.
Thank you,
Thank you.
everyone.
See you guys
Thank you
soon.
for joining. Bye bye. See you
Thank
soon.
you.
Bye.
Ayush, I think we lost you when you were traveling, so I finished
Yeah,
it.
yeah.
Yeah.
I just had to
Yeah.
rush. Okay.
Sure.
Thank you.
Thank you. Thank you all. ऑर्थो टीवी कौन है?